Good morning and welcome to the Davies Use Case webinar being presented by Novant Health, RCS Management System Benefit Realization. This is Davies award-winning use case for the Value of Health IT. My name is Joel Simmons, and I'm Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core mission is promoting the use of health IT to improve quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, adds to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. Pleasure to speakers for today's webinar. We have April York. Ms. York is the Senior Director of Acute Financial Services for Novant Health. April is directly responsible for enhancing the process capability and ensuring the integrity of Novant Health's revenue cycle system, net revenue of $3 billion annual. She is a science degree in accounting and has been a Novant Health team member for 17 years. And Mr. Drawn, Mrs. Hester Drawn is the Senior Director of Novant Health Revenue Cycle Service Team. Angela oversees the operation of the Customer Service Contact Center and registration for the ambulatory group. She got her undergraduate degree from High Point University and has been a team member with Health for 10 years. I would like to thank you both for joining us today and welcome you both on the call.
Hello, April York with Novant Health, and I appreciate the opportunity to share with you today our benefit realization as a result of the implementation of our Revenue Cycle Services Management System, the steps that we took prior to that implementation to ensure its success. Opportunity to introduce Novant Health Revenue Cycle Team first before we move through and navigate this presentation today. The Revenue Cycle Team has been recognized for strong or outstanding financial performance with the positive patient experience. We have been recognized with industry-leading key performance indicators in multiple areas. But most important and differentiates us in the industry is our approach to our patient collection effort. And in the center of that slide, I'm going to read that section. Every account you touch affects someone's life. Take each day to celebrate each and every life you have impacted. It's very important to us as we look at an encounter that we do not look at those as individual account numbers or dates of service or the cash that comes in the door. But as an encounter pops up in a work queue, we have the opportunity to see the patient's face and that we develop a relationship with that patient when we're speaking with them, and that we engage with every patient uniquely based on their circumstances and their situation. And that is a culture that we strive to instill in each of our team members within Revenue Cycle Services. About the overall implementation of the system and the performance outcomes, I need to take us back a few years. In 2009, Revenue Cycle Services began a journey towards standardization that ultimately ended up in the selection and implementation of a single Novant Health Revenue Cycle platform for both ambulatory and acute care services. The implementation for ambulatory began 2 years earlier than our acute care services, so in 2011. And Angela is going to talk a little bit more about what that looked like during that time. we made this decision to have our ambulatory, our physician partners, go through this process prior to acute care implementation. We want to ensure that our physicians understood the system, knew the system, knew how it functioned, and were able to create a remarkable patient experience in the acute care setting as well when we moved and went live on the acute care side. So our first go live for acute care was fourth quarter actually of 2013. Went live in October of 2013 with a single hospital system and had a multi-phase rollout. As many healthcare systems are aware and have experience with multiple platforms come many issues or areas of opportunity. Validated reporting for us was very cumbersome. Standard operating procedures were virtually impossible to create, and performance metrics were not always industry-leading for us. All items ultimately led to an inconsistent patient experience and inconsistencies in operational performance. That inconsistent patient experience patients in at a physician's office, they present at an acute care location, they may present at one of our freestanding imaging centers. Every experience was different. Who they expected to follow up on their bill was different. Who they contacted to reach out for financial assistance, and the way that they established a payment plan, again, was very different. We have multiple platforms. We were unable to consolidate that experience, and so we knew organizationally that we had to change, and we had to leverage technology to make that happen. Collections were strong. We weren't leaving money on the table, but our average days to collect that cash were excessive, so it was costing us more to collect the same dollar. AOs were in excess of 44 days. Our receivables were nearing 30%. We had a non-standard patient collection strategy, as I just discussed. We were unable to inform our patients with a great degree of confidence of their out-of-pocket costs prior to service, just because we did not have that transparency or the ability to populate that information in a system and push that forward in the process for our team members to be able to have the conversation. We had the inability to consistently collect prior to or at the point of service. We didn't have access to denials data, resulting ultimately in a loss of cash. There was also confusing regarding who to contact and what services they were being billed for. And to address these obstacles, again, we had to move forward and we had to leverage technology to be able to do that. But we had to ultimately define what we wanted and what our vision needed to be. Defining that vision, a few of our defining principles were improvement. We knew that we wanted improvement in tools to aid in the understanding of our patients and their needs. We needed streamlined and standardized processes prior to the implementation of this system. The system needed to be clear and easy to understand, that we needed to understand those expectations for our patients. We knew we needed to have a robust training program as we moved and started to walk in this direction. We knew develop for me, and I put that in quotations, meaning easy for the patient. It needed to be easy for the patient concept so that the patients would be able to engage with our organization, and again, it would be easy for them. All would ultimately lead to the opportunities for our team members to deliver what we as an organization define as a remarkable patient experience. I think importantly, though, we learned that we must change the way we were doing business today in order to achieve the ultimate vision for the future. And so now I'll walk through the journey just a little bit before we get to the technology piece of it. 2007, we started on this journey from a revenue cycle perspective. The revenue cycle team began a multi-phase transformation journey that spanned quite a few years, you will see. Each of this transformation was an essential step to lead toward the next one. In phase one, we had the creation of our revenue cycle transformation roadmap, and ultimately defined the endpoints and outlined the steps to obtain that revenue cycle transformation. In 2008 to 2009, which was our phase 2, we started planning and preparation and ultimately implementation of this roadmap. Again, all leading us through the journey to ultimate system selection and creating a single platform and a single patient experience. It's essentially to establish that centralized office or revenue cycle services and that standardized foundation for that future differentiation. At this particular point in time, we had created centralized business offices. We had created and we're walking through centralized processes, but we still had multiple platforms that we were still having to utilize. So when a patient would call in, for example, we would navigate different spaces. When we would follow up on accounts or we're billing out claims to payers, we were billing for multiple systems, so it was very inefficient. But we knew that we had to make these decisions and begin the standardization process in order to build the system for the future and ultimately yield the benefit that we have today. So actually started the implementation of our system. As I stated, it was October 2013 when we went live for the first one, first facility, and that system, that process was to enhance that patient experience and ultimately drive financial improvement. It's kind of where we sit today. In 2015, we still had some additional facilities that we needed to roll out, but we needed to kind of into that phase 5 where we began to, the systems that were already live, we started focusing on stabilization of metrics and performance, looking at consistent quality, and ensuring that the processes and the work and the design that we had within that system was going to be functional long term. And not only looking at stabilization, but ultimately in some areas beginning to move into that optimization phase. When we get to that phase 5, we had to start with our people. And it seems to be, system implementation is very challenging, but if your people aren't aligned and your people aren't on board, then it becomes an implementation nightmare. And so we wanted to make sure that we engaged with our people as far upstream as we possibly could, as early as we could, to help manage this change. Pre-implementation looked just like this. The customer service contact center, we had actually 2 of them, care services, and then we had one for ambulatory. We had patient access. We had master and charge integrity, that was a combined team. HR coding were consolidated, and financial services. And our nice revenue cycle. And it functioned very well in the old strategy, the old platform. But as we looked at a new system, we needed to modify that. The cycle team as it is today, much like this, very blended between ambulatory and acute care services in our patient-facing areas. So scheduling and pre-service, on access. Scheduling and pre-service, we were able to call out and a true scheduling pre-service area because the system now had the ability to, we were able to put information further upstream, give our schedulers in our pre-visit areas, create that what we call a schedustration model, and give them the data to be able to have a proactive conversation with our patients before they present and tell them they're out of pocket with a great degree of confidence, navigate payment plans, check applications, do what they need to do for that patient so that when that patient presents, they're as educated as we can possibly educate them on what that particular procedure is going to cost. Access. A unique area generally for revenue cycle services is utilization review. General management utilization review are kind of a single team that lives within the facility itself we made the decision to carve out utilization review because it's the financial component of care management, and felt that it lived under revenue cycle services. And the technology that we had implemented allowed us to do that. We could carve out and develop work queues that designed a strategy that was going to be effective for us long term and ultimately yield an improvement in net reimbursement. Integrity and charge integrity were a single department. Carve those out, and because charge integrity to us was stabilization of a charge master, making sure that the data itself remains intact, that the CPT codes are loaded, that the pricing strategy is what it needs to be. Revenue integrity for us really was working with the departments and developing that relationship from an education perspective to be able to help them understand where there is missed revenue opportunity. Constantly researching to understand where we may or may not have missed revenue opportunity, overcharging, undercharging. And we built this new revenue integrity team to support our future state. 18 were again broken out because we're able to build out a release of information team, inclusive of ambulatory and acute. And the patient financial services remained as it is. Under all of this, you'll see that we have education and training and revenue cycle analytics and systems. Again, that is representative of both ambulatory and acute to create a consistent approach to how that training takes place, because a lot of data that is now shared that improves our overall process and reduces our cost overall. This RED network for revenue cycle services, this was a revenue cycle advisory team that was established pre-system implementation to help ensure that the standardization we had created remains intact long term. This revenue cycle advisory committee exists even today. Its purpose really is to aid in making decisions and ensure that our revenue cycle, that clinical teams are not making decisions that could ultimately impact revenue cycle services and vice versa. That revenue cycle is not making decisions that would impact clinical workflows or processes or how they charge, inadvertently making those decisions that without knowing that there would be an impact downstream. So, if a clinical team has a potential revenue cycle or charge impact, if that decision is approved, it also has to be signed off on from a revenue cycle advisory committee perspective. And again, this committee still exists today and is representative of both ambulatory and acute care partners to, again, ensure that we remain standard, and it helps to create that stability within the system. A little bit through some of the outcomes that we have seen as a result of the system implementation, some of our performance metrics. So in 2013, our baseline performance for discharge not final billed was at 5.87 days. In 2016, we have reduced that by nearly a day. A day for our organization represents about $23 million. To kind of give you an idea of the dollar value associated with that single day. These are accounts that would have been held up in the system for claim edits, coding, just something that, meaning that it had exceeded our normal billing threshold, our threshold, ready to be billed but couldn't because there was an error or something holding that up. Revenue in accounts receivable was a little over 44 days. Sitting at 36 days, year-end 2016. Sales, there's an applicable there because we couldn't track it. We have access to data to be able to understand what that was. In 2014, we were at 4%. We're down to 3.3%, and there's some detailed slides on each of these metrics that we'll discuss in just a moment. Our greater than 90 days, or our aged accounts receivable, was a little over 27%, almost 28%. We're down to 20% now. Ultimately, what that means is as an account ages, obviously, it becomes less collectible. As it's less collectible, you have to reserve or book additional expense from a finance perspective. And so when your aged receivables become much cleaner, there's a reduction in cost, there's a reduction in expense associated with being able to collect those dollars sooner. Went from 2.03% to 1.5%. And the cost to collect, while that looks incremental from a value perspective, we'll convert that to cash and expense and show you on the next slide what that ultimately yields. Had we continued at the current cost to collect rate, we have booked an additional $9 million more in 2016 in expense to collect the same amount of cash. In the table there in 2015, we would have booked an additional $15 million in expense to collect the same amount of cash. Again, had we not built processes and built the system out to help us ultimately reduce this cost. So we leveraged the system and the technology to, and it wasn't all staffing. As a matter of fact, it was less staffing and more about vendor cost. We were sending fewer statements because we could quantify our accounts better. I'll give you an example. We were able to partner with an external vendor to pull in data that would tell us the patient's ability to pay, and we fall within the federal poverty level. That was populated at the point of discharge for patients, so our financial counselors had access to that data. When it was time to actually collect on a patient liability, we would consciously make decisions to not send patient statements based on a patient's ability to pay, because we may want to have a conversation with them over the phone to establish a payment arrangement. We may want to navigate them through charity care or work with them to establish Medicaid eligibility and get them set up with the state. So we had access and could feed data into the system to then generate workflows that would allow us to more efficiently work these accounts and place our patients and their accounts in buckets that met their need and was more specific to them and their unique situation. That led to reduced costs. The system to ultimately improve overall performance is the implementation of our claim edits. Historically, our claim edits lived in an external claim scrubber. We took any of those claim edits and we built them into our single platform and pushed those claim edits further upstream, not only to create efficiencies and get those claims out the door cleaner, but also to get them out the door quicker. So the edit may live with radiology. It very well could live with the laboratory. Maybe it's coding. Maybe it's registration. We wanted to make sure that the billing team just didn't have edits sitting in a claim scrubber where they were emailing a department waiting on a response, which we all know is a very inefficient process, and many times you may or may not get a response back. Have to follow up on that subsequently. Very manual. This is to streamline that and make it more automated so that we get some accountability. We were able to implement what's called NEIC rejections, and these are your payer responses that tell you whether the claim actually made it into the payer's door or not, many of your managed care payers. And the NEIC rejections historically had come back in a paper format. You had no ability to track whether the paper had been worked or not. Those claims had been resubmitted back out the door. We were able to take that data, create a file, and upload that into the system that then generated work queues that could be worked in real time. Work queues, again, help to improve this overall claim acceptance percentage, move our claim validation further upstream. So we ended our clean claim rate in 2016 was almost 91%. I can say today we're sitting in 2017 at about 96% clean claim rate. In cost to collect that we just talked about, a direct correlation on cash collections as well. You'll see the overall improvement in cash over a 3-year period is an improvement. We collect an additional $79 million, which for us organizationally is $79 million more to reinvest in improving the health of our communities. Across the bottom of that graph that's there, you'll see cash to net percentage. Again, cash to net was always very strong. It was the timing in which the time that it took to collect that cash and how often we had to rework an account to be able to do so. As we improved that clean claim rate, as claims going out the door, we saw denial reductions and we saw cash acceleration and, again, reduction in overall cost, all leveraging the technology of the system itself. We talked earlier about, or mentioned earlier about the ability to load the data in the system, push that further upstream, ensuring that our team members had access to that data. You'll see a 58% increase in pre-service collection over 2015, from $2.3 million to $3.7 million, and all of that was done even with a reduction in staffing. So we did see a reduction here. We were still able to improve overall collections, so we reduced by 3 FTEs in a particular area. Still continued to see an improvement in collection, all through leveraging the system, workflow redesign, and improvement in work queues, access to data. The reduction, again, was driven through benefit transparency that could not be built out within the system that we had previously, but now was readily available for our teams while they were speaking to the patient. Point of collections also increased, and we saw a significant increase even from 2015 to 2016. But if we go back even further than that, you can look in 2009 when we started this revenue cycle transformation with $1.9 million in point of services collection. In 2016, we ended at nearly $25 million. Again, the further upstream you collect, the more collectible an account is, the more likely you are to collect on that account, and the less money you spend from a cost perspective in patient statements and dialers and calling patients, staffing. It ultimately yields in that reduction in cost to collect as well. Our regen times decreased by a minute, so we are sitting at 4.91, which is below the best, what's defined as best for HIMSS access key metric, which is the target is 5 minutes, and a lot of that has to do with our ability to share data from an ambulatory and acute perspective, and the ability to store that data visit over visit. So if a patient was seen here 3 weeks ago, we still have that same information. We do not have to re-ask those questions every time a patient presents at our location. It's very much a patient satisfier, it's a team member satisfier, and ultimately yields the overall process improvement in data accuracy. Access to denials data now. And what's key, though, having access to data alone does not yield performance improvement. You have action on that data once you have it. And so in 2014, that was our first year to be able to have access to that data. We developed action plans associated with each of those denials and implement those steps, ultimately leading to a reduction to 3.3% in December of 2016 when we measured that. Much of that improvement was a direct correlation between, again, access to the data and developing action plans based on that data. And a particular one that I want to focus on is utilization review. And in that utilization review area, through new work queue development and workflow redesign, as a benefit of that single platform that we now have, we were able to decrease our incorrect level of care, our medical necessity, and our inpatient-only write-offs by $4.4 million. And that's not denials, that's true write-offs. So that $4.4 million yielded an additional cash collection of $4.4 million. So very excited about those outcomes. Very overall progress and very evident that the system design itself and the workflows that we have in place are effective. And release of information team, the shared platform allowed for us to implement a comprehensive career ladder approach. Because again, we had a shared platform. We created a consistent strategy across both ambulatory and acute, and so we were able to completely overhaul and modernize the job descriptions, the titles, the salary ranges, and create that overall career platform. We also successfully launched the MyChart release of information functionality to the public. Our patients are more self-service, not only with their records themselves, but also in access to their bills online, being able to schedule visits with their physicians, just all kinds of information. And as an organization, we want to put the power of this technology into the patient's hands. I've seen in many of our market research studies that patients want to be very transactional until they don't. And at that point, they want it to be very much relationship-based. And they want to know you, and they want you to know them, and they want you to respect them and understand their unique circumstance, and they want you to develop a process and a relationship with them based on that uniqueness. So that transactional approach is where we are headed as an organization, and we have been very successful in pushing that power back out to those patients. Other things that I wanted to highlight from a patient financial services perspective, and Angela's going to get very detailed into one of our Easy for Me projects that really drove our overall improvement in patient experience. We did implement a couple of other Easy for projects. One of them was our guarantor collections, and between ambulatory and acute. We moved forward, even though we are not single business office. We did move forward with the consolidation of those two areas from a reporting structure perspective and from a process and procedure perspective. We're still navigating that space a little bit, but have seen some success there. We implemented a dialer system, a bolt-on, it's a cloud dialer for our guarantor collections, and again, it's inclusive of ambulatory and acute. And it's an increased patient communication and improved patient collections for the system. One area that we have seen that consolidated is our contract management team as well. So we're able to load our ambulatory and acute care payer contracts into the system to be able to monitor payer performance. From an perspective, we saw recoveries for acute in excess of $9 million in a single year in 2016. Now, those two areas consolidated, we can leverage that consolidation and that reporting structure to have meetings with payers to escalate our issues consistently using a standardized approach and to ensure that our physician partners are getting the attention on their issues from a claims perspective, just like the acute care locations that have the bigger dollars. It's important that as an organization we are representative of both. The system to create a release of information team, a consolidated release of information team that now has become revenue producing, and in 2016 we were able to actually collect $875,000 from a cash perspective through invoicing their attorney payers based on contract if they had requested copies of medical records, patients at times. So again, there is a cost associated with that printing of that record or emailing that record, whatever it may be, and so we have now been able to have some return on investment as a result of that consolidation and leveraging the system to be able to send out those invoices and bill for that. Over to Angela, and she's going to walk us through our customer service department consolidation and the Easy for Me project, and ultimately how that has improved our patient experience.
Hi, Newcastle Drawn. Today we will be reviewing the Revenue Cycle Services Customer Service Contact Center, the steps we took to make significant changes to make the process easier for our patients and our team members. It would not have been possible without the implementation of Epic and our IT partners. Before the implementation of Epic, between 2008 and 2011, we want to do a reflection in time. Novant was operating on 12 internal patient accounting systems with over 100 independent clinics hosting their own standalone patient accounting system. During the combined acute and ambulatory departments had 78 customer service representatives, 40,000 calls on average a month. Our talk time was 5 minutes and 30 seconds. Average wait time was 3 minutes. Again, billed for 227 physician clinics, 100 of them being independent, and 14 facilities. Close the Epic implementation, we began evaluating our patient concerns. We began with customer service and how we could eliminate those concerns through the use of the system, our new technology. 2 separate phone numbers for patients dependent on service line. Each department had multiple email addresses for concerns to come to, as well as processes. Team members were limited to helping patients based on department domain. Novant Revenue Cycle Platform is an Epic PBHB structure. Our inventory Epic Go Live began in 2011 through 2013 for all 464 clinics. A Go Live followed beginning in 2013 through 2016 for facilities and joint ventures. In 2017, we went live with our imaging centers on Epic. We were to our brand initiative to operate as one single Novant Health entity. The starting focal point was our customer service department. We knew to convert the customer service department into a single contact department for our patients and team members. This consolidation needed to be seamless to our patients and also to provide one call resolution regardless of where the patient received their services at Novant Health. In December 2014, the acute and ambulatory revenue cycle services leaders developed a program called Easy for Me, in which we began to explore all points of access that our patients go through when they enter the revenue cycle billing experience. Novant Health was implemented as an Epic PBHB structure, recognized that an overlap existed across the revenue cycle, which impacted our patients' billing experience. Technology to the best of our ability. Our team charged with identifying the repetitive patient touch points across the revenue cycle billing process and developing solutions that would be presented to the overall revenue cycle group. Our goal was to make the revenue cycle process easier for the patients as well as our team members. One of our biggest areas of opportunity that we identified as a duplicative patient touch point was our separate acute and ambulatory customer service teams. It was for a patient to call in for a question about their physician bill and to make a separate call to get questions answered about their hospital bill. Provided feedback regarding the confusion created by the difference in process between acute and ambulatory billing. Team members did not communicate across departments. We were in separate locations and did not interact. They were confused on where and how to route calls, and processes were different. This created challenges for team members to be able to assist customers with hospital and physician billing inquiries. Members did not take payments outside of their service area. Therefore, the transfer of calls to make payments to separate service areas occur. Half-year plan on how to overcome our obstacles, which are currently at the end of the plan with stabilization in mind. Several phases in which there's 8 phases that we built out originally. Phase 1, in November 2015, we created one phone number for both acute and ambulatory customer service. Phase 2, we consolidated the management structure, aligned the bonus guidelines and the weekly and monthly statistics, and consolidated the team goal to one. It was in March of 2016. We reviewed all the standard operating procedures and timeline implemented for merging the department policies. In June 2016, we implemented a new statement vendor, which was not planned, across our acute and ambulatory, which includes adding new phone trees and our IVR phone system to the system. Phase 5, which was July 2016, we began cross-training our internal customer service representatives. Those representatives were responsible for replying to emails, iChat, and in-basket messages. Since this was a smaller group, we thought they could pilot the program for us to see how it turned out. November 2016 to February 27, we began cross-training all customer service representatives. That is currently in motion is the stabilization of the combined customer service areas. So in the obstacles and the solutions, we began 2 departments that did not interact, consolidated to one customer service department. We had numbers for customer service, moved one telephone number with easy phone tree, a breakdown between hospital and physician, which will end up being no distinction as customer service can answer any call regardless of place of service. We had email addresses, we consolidated to one, chat sessions, consolidated to one, and 2 in-basket pools, which we also consolidated to one. At the point that we originally began the consolidation of the customer service department before the training of both sides of the system, we wanted to start small. So we started to provide dual access to both sides of the system to our team members so they could at least take payments for each side regardless of service line. And so we provided them with dual access as well as training on that simple function and dual monitor screens. Our option for call was make a payment and balance inquiry, and we'll give some data around this in a few minutes. So we implemented an IVR to our phone system for patients to be able to hear their balance information and make a payment over the phone. Ours is in looking back in 2010 compared to 2017. In 2010, our total calls received each month was 40,000. Today, we're at 48,000. Our number of FTEs in 2010 was 78. Today, we're at 53. And the consolidated acute and ambulatory. Answered in less than 120 seconds in 2010 was 53%, and in 2017 at 89%. Our field have drastically doubled. In 2010, we had 227 clinics, 100 of those were independent, and today we have